Okay, can everyone hear me?
Yes.
Okay, so let's go ahead and get started. I'm Dr. Ashley Autry. I'm our project leader for the REACH initiative here in Louisiana, and we also have nurses and participants joining from other states throughout the Gulf States region. So we welcome all of y'all and thank you for being here. We're going to do some more introductions a little bit later, but first I wanted to turn it over to Maggie, our project coordinator, and she's just going to go through some disclosures, some Zoom etiquette, and just some basic ground rules before we get started, okay? Maggie, go ahead.
All
and
right.
if everyone else doesn't mind muting, thank you.
Hi, everyone. My name's Maggie. I am one of the program coordinators for our REACH program. So just some housekeeping things that I'll go over. Firstly, just initial disclosures. Project ECHO and REACH are going to be collecting data for this project. This is really just to improve the program and future initiatives. So this will be just regarding registration, participation, and chat comments. And your individual data will be kept confidential. For education purposes, we are going to be recording the session, and these will be provided at a later point, hopefully in about a week or so. You'll be receiving an email from me with the link to accessing this. And this will be for if you'd like to access the session again, or for people that were not able to be here, they can access that at the website. And by participating in this session, you are consenting to being recorded. That's just a note. If there's any questions that you have about this, feel free to shoot us an email at reach@lmhpco.org. We are very excited to be accredited through LMHPCO to be able to offer continuing education units to our nurses. So if you are a nurse, you're welcome to claim these credits. Each session is 1.5 units. We will be tracking attendance at each session. It's not a bad idea if you'd like to also keep track of your attendance, just in case we need to cross-check, but we'll be monitoring that. LMHPCO will also be collecting evaluations following each session. So just be sure to complete those. That will be an email that will be sent out to you. So just be sure to complete those evaluations after the sessions in order to claim credit. Additionally, if you are a hospice nurse, you're going to be eligible to participate in the REACH initiative, which is a quality improvement project. That's completely voluntary and does not affect the CEU process, but you should have received an email from the reach@lmhpco email via SurveyMonkey. So those will be 3 surveys that you'll be asked to complete. One is at the beginning of this program, so that one should have already been sent out to you. If you did not receive it, or you are a hospice nurse and haven't gotten an email from me, then just shoot us an email and we will get that to you. But that one email or one survey at the beginning of this the program is to be completed, and then we'll send another one out in about 6 months, and then one at the completion of the program. So again, that's voluntary and for hospice nurses. Okay, just some Zoom etiquette. If you don't mind just muting I think everyone should be muted automatically. We do welcome you to come off mute and share any comments or questions that you have at any point. But just stay muted when you're not speaking. And after you do speak, be sure to mute yourself. So that we can hear you, just speak as close to the microphone as possible. And then also, if you could keep your camera on if you have the bandwidth, that will just help us to increase engagement and get to know each other. So we also understand if you're not in a space that enables camera usage, but we would love to see your faces. If you do experience IT issues, feel free to chat me in the message or in the chat box. My name's Maggie, and I can provide you assistance. And again, just some more Zoom etiquette. This is important if you don't mind renaming yourselves. If you go to the 3 dots on your screen in Zoom, you can, or if you click participants and find your name and click rename, and then if you don't mind putting your first name, your last name, and then your hospice organization, that way I can track attendance. And then again, just during the sessions, we welcome comments, questions. You can either raise your hand, use the icon to raise your hand if you'd like to speak, or you can feel free to use the chat to make any comments or questions. I'll be monitoring that. Okay, and finally, just some ground rules. We want to make everyone feel comfortable and welcome. So this is a safe space. Everyone's questions, thoughts, concerns are valid and are valuable. And we want to use this space to encourage open dialogue and reflection. So kind of like Vegas, what's said here stays here. And we hope that you do use real life examples from your work settings during the discussions. Just be sure to share de-identified information only. All righty, I think that's all I have.
Thanks, Maggie. So before we get started, I just wanted to go through a brief kind of outline of our session today. So we'll start today's session with a formal welcome and introduce some of the team members within the REACH initiative. We'll also introduce the Project ECHO program. It's helpful to understand both the background of REACH as well as Project ECHO and how these two things are really coming together to provide this great teleeducation opportunity. Next, we will review how pediatric hospice differs from adult hospice, particularly with concurrent care. And then we will discuss a case and we'll have our experts weigh in. And then finally, we'll wrap up the session and start talking about future sessions and do a mindfulness activity as well before we end the day. At the start of each future session, we will briefly review an agenda and objectives for the session. But today, our objectives also serve as our agenda to outline the flow. Okay, so I'd like to officially welcome you to the REACH initiative. Again, we're really excited that y'all are here. My name's Ashley Autry, and I'm a pediatric palliative care attending at Children's Hospital New Orleans. I did my training at St. Jude Children's Research Hospital, and it's my colleagues there who really started to develop the REACH initiative. And so we're really lucky to be able to help kind of pilot this work and this education across our Gulf State region. So I have the privilege of leading the Gulf State region REACH initiative, and I'll be one of your facilitators over the monthly sessions throughout the year. To start, I'm going to ask the members of the REACH team, our Gulf State region REACH team, to introduce themselves briefly. This team has worked really hard over the past couple of months to launch this initiative, and they will certainly help us keep moving forward throughout the year. So let's go ahead and start with our other 2 facilitators. It'll be myself, Stevia, our nurse practitioner, and Dr. Morvant. Stevia, do you want to go ahead and introduce yourself first?
Hi, I'm Stevia Davis. I am the nurse practitioner on the pediatric palliative care team at Shinola. I was born and raised in Ohio and trained up in Cleveland, and was part of the palliative care team at Rainbow Babies Hospital, and then was drawn down here to work with this amazing team.
Thanks, Stevia. And Stevia will also kind of be taking over as project leader when I'm out on maternity leave starting next month. So just for a few months, she'll be helping out extra. Dr. Morvant, do you mind introducing yourself?
Yeah, sure. Hey, y'all. I am so excited. I want to give super duper big props to Dr. Autry for getting this going and partnering with St. Jude's to bring this to our community and our region. So yeah, I'm Dr. Morvant. Everybody calls me Dr. Mo. Born and raised in Thibodaux, Louisiana, in the Bayou, and I did my training at Vanderbilt for my peds residency, and then I did my pediatric hospice and palliative medicine fellowship at Harvard. And then came back here in 2018 to be the chief of pediatric palliative care at Children's Hospital New Orleans. and I'm the founder and chair of our Gulf States Pediatric Palliative Care Consortium, and super excited to be here and see this come to fruition so that we could continue to be a source for education to improve serious illness care of our most precious kiddos in our Gulf States region.
Thanks, Dr. Morvant. Next, I'm going to have our program project coordinators, Maggie and Masood, introduce themselves briefly. Maggie, you want to go first?
Yeah. Hey, everyone. I'm Maggie. I'm from Covington, Louisiana. I'm actually a student and volunteer researcher right now. So Dr. Autry kindly invited me to join the team as program coordinator. But I went to Rhodes College in Memphis for my undergrad and had some really incredible experiences volunteering and shadowing with palliative care and hospice up there. So as I apply to med school, I just am really interested in learning more. So happy to be here.
And Masood?
Hey everyone, my name is Masood. I'm originally from Marietta, Georgia. I came down to New Orleans about 8 years ago to study public health at Tulane, both undergrad and grad school. I work at the Children's Hospital here, supporting the palliative care team as a practice administrator, and I'm just here to help with whatever coordinating needs Dr. Autry or Maggie has.
Thanks, Masood. And also our partners at LMHPCO, Jamie Boudreau and Marquetta. Jamie, do you want to introduce yourself first?
Okay. I'm Jamie Boudreau with the Louisiana Mississippi Hospice and Palliative Care Organization. And we're very excited to be partnering with the coalition as well as with Children's to bring a continuing education to nurses in Louisiana and Mississippi, especially. I know we have some nurses from as far away as Massachusetts who registered this morning, so welcome. The thing that I want to remind everyone of is that you now have your email that we have is now your profile username to allow you into the website, which will give you pages, the reach page you'll be able to reach. We're creating just a reach page for you all who are participating in this project so that you'll have access to all that source material after the fact. But we also use a system called PlanStone, and I know Marquetta is having some connectivity issues today, so she asked me to pass this information on to you after today's session and after every session, every monthly session. You will receive an email from Marquetta at lmhpco.org. It's coming through a system called PlanStone, which is a system that we use to track continuing education. You receive that link. It will take you to an evaluation of the session that you just experienced. We need your evaluation. In order to claim your hour and a half of continuing education, you have to provide us with an evaluation of that previous 90 minutes. So I think I covered everything. Just know that your username is either for accessing our website or for PlanStone is going to be the email address that you have given us in your registration. And then you'll have to make up your own password. It'll allow you to reset your password, and you can just push reset and you put whatever password you put in there. Thank you again for letting us be part of this exciting program.
Thank you, Jamie. And then also, last but not least, we have Stacy Melling, and she is our integrative therapist, and she's going to be leading our mindfulness activities throughout the year. Stacy, do you want to go ahead and introduce yourself?
Hey, can you hear me okay?
Mm-hmm.
Stacy Melling, I'm a nurse at Children's Hospital. Been here for almost 25 years, and I do integrative therapies. I work very closely with the palliative care team, and I look forward to being with y'all. And if you have questions, feel free to shoot it. We'll share the emails and stuff, I'm sure, later. So if you have questions, reach out. Pleasure to be here.
Thanks, Stacy. Okay, now that you've all met the REACH team, I'd love to take a moment for everyone else to introduce themselves so we can start getting to know each other. Just saying your last name and the organization that you work for, and where you're and where you're located. I'm just going to go alphabetically off the participant list. Anitra Dunbar.
Hi, I'm Anitra Dunbar. I'm the administrator of Allegiance Hospice and Palliative Care. I am located in Marksville, Louisiana. We also service a 50-mile radius, including Alexandria.
Awesome. Thank you, Anitra. Brianna Gilbert. Brianna might be having trouble with audio. Brianna, feel free to put it in the chat and we'll go ahead and move on to Brooke. Brooke? And remember to unmute yourself when you speak. Okay, Cheryl?
Good afternoon, everyone. I'm Cheryl Churn. I'm the maternal fetal medicine nurse navigator for LCMC. So I work with the families when they have a high-risk pregnancy or delivery, or we're going to have a sick baby after, and I follow them through the pregnancy and beyond. And I'm based out of Children's Hospital in New Orleans.
Thanks, Cheryl. Cindy Fowler?
Hi, my name is Cindy Fowler. I'm the Director of Nursing for St. Tammany Parish Hospice. We're located in Covington and we service a 50-mile radius on the North Shore. So Slidell, Bogalusa, Tangi, that whole, we go in that whole area.
Awesome. So already Alexandria area and North Shore area. Thank you. Courtney Kelly?
Hi, I'm Courtney Kelly. I'm the clinical operations coordinator for the hospice service line for LHC Group. We were formerly the Heart of Hospice Kids at Heart team. We service the entire state of Louisiana right now. And we are currently working on building back our pediatrics program and launching that across the country.
Awesome. Well, welcome, Courtney. And then Jessica Graham.
Yes, hi, I'm Jessica from Allegiance Hospice and Palliative Care in Ruston, and I'm the administrator there.
Hey, Jessica, thanks for joining.
Thank you.
Laura Mooney.
Hi, hello, I'm Laura Mooney. I am the Regional Director of Quality Outcomes for Compassus.
Awesome. Hi, Laura. And then there are 3 people on the phone. Do any of y'all mind sharing, introducing yourselves and sharing your name and which organization you're affiliated with?
Can you hear me?
Yes.
I'm Stephanie Diffie. I am a case manager for Allegiance Hospice in Ruston, Louisiana.
Awesome. Nice to meet you, Stephanie. Anyone else on the phone want to share? Okay, I think that's everyone. Let's go ahead and get started. Okay, so as I mentioned before, over the past year, our colleagues at St. Jude Children's Research Hospital have worked alongside an amazing community advisory board of 17 key stakeholders, including hospice nurses, hospice administrators, hospice chaplains, and social work, as well as bereaved parents within the state of Tennessee. And they've leaned on them to guide the development of this initiative, including how it's given, what the content is. So we are so grateful for all their hard work in helping us create this model, and wanted to take a moment to review their vision and their mission, which we have adopted here in Louisiana for our Gulf States REACH initiative. So vision is for hospice nurses in the Gulf States region to have access to expert pediatric specific training and support to empower them in provision of high quality compassionate care to children and their families. And through our partnership with Project ECHO, we'll provide evidence-based knowledge, resources, peer support, and community for hospice nurses across our state. And so that's why we really encourage everyone to put their camera on when they can and to share throughout the sessions, because we really hope that this can be a community over the next year and for the future to help improve the care of children in our area. But together, the REACH team and the Community Advisory Board members came up with the hub and spoke model. So the goal is to use this model to connect the experts, meaning the hub, to community hospice nurses, being the spokes, and to form a network of learning and support. And Project ECHO is a very well-established example of a hub and spoke model. It is a knowledge sharing network that connects multidisciplinary teams of experts with health professionals in the community via a video conference model. So Project ECHO emphasizes an all teach, all learn approach. Again, the speakers teaching, but also all of the participants on the call, all of y'all sharing your experiences and the care that you're providing in your areas too, so we can all learn from each other. And the goal is to move the knowledge instead of moving people. So I just want to share this video. Project ECHO was initially started by Dr. Aurora in the early 2000s to improve hepatitis C care for patients in New Mexico. He's a GI subspecialist. So he acted as the expert hub and virtually connected with many community providers and adult medicine primary care providers to improve access to subspecialty care and deliver hepatitis C management. And what he found was that this model was actually very successful, and he was able to publish, not only improve care, but also publish his findings in the New England Journal of Medicine. I'm just going to click this link and he tells his story briefly.
I'm a hepatitis C specialist, and I was treating hepatitis C at the University of New Mexico in my clinic. And I recall a patient she was a 43-year-old woman, and she came to see me, and there was an 8-month wait to see me in my clinic. And people were driving hundreds of miles to see me, 200 miles each way, and would have to make 12 to 18 trips to get treatment because treatment involved weekly injections with interferon and another medicine that caused anemia called ribavirin. When she saw me, she had, 2 children. One was her son, 14 years old. She had a daughter who was 9. And she wanted treatment for hepatitis C. She'd been diagnosed hepatitis C many years. Her husband had passed away in a car accident 5 years earlier, so she was a single mother. And when I saw her, she had cancer of the liver already, size of a baseball, and she wanted to live because she had 2 children, and there's nothing we can do. And she died of a disease, terrible, because there were no doctors in her area that had the ability or the knowledge to treat hepatitis C. And over the years, I've had more than 100 patients like that who died of hepatitis C related liver cancer when this was totally preventable. And because of the 8-month wait and the long drives, poor people couldn't access me. And but I had to do something else to bring access to care. Everyone in New Mexico who had this disease, so more people didn't die of liver failure and liver cancers. And that's how I started Project ECHO, to bring access to care for hepatitis C treatment to everyone. And then I knew if I could do that, then I would have a model for complex diseases and rural locations and other countries.
Sorry, lost my place in our slideshow. Okay, and so fast forward 20 years, and now there are over 1,700 programs that partner with Project ECHO in almost 70 countries, and obviously growing every day. Various organizations are partnering with Project ECHO to use their teleeducation and networking model in order to provide education and support around a wide variety of topics, ranging from prenatal care to pain management to obviously pediatric palliative care, with sick kids in Toronto being one of the main examples, aside from us, of course. So our REACH initiative with our colleagues at St. Jude and Project ECHO, combine the two and you get our Gulf States region REACH Pediatric Palliative Care and Hospice ECHO. And so we hope that this is a convenient and easily accessible environment that connects experts with all of y'all in the community. And we hope to share evidence-based pediatric education and empower all of you to continue to deliver high quality and compassionate care to children and their families. And we're committed to providing these sessions for all of our hospice nurses in the community, and also welcome other interdisciplinary participants such as our case managers and hospice administrators and everyone else. So this is what our ECHO program is going to look like over the next few months. So we'll have virtual sessions monthly on the third Thursday of the month from 12 to 1:30 p.m. Hopefully this is during a lunch break or a time where you guys can listen in. And again, if not, if you have to miss a certain session, there will be recordings available for you to look at a later date. The only caveat to this, which we will remind you a lot about, is December. It will not be the third Thursday of the month. It'll actually be the second, just to not be too close to the holidays, but that's far away from now. But just wanted to kind of mention it. So we'll start with welcome announcements and introductions like we did today. And then we'll go into a didactic presentation. And this will be led by pediatric palliative care and hospice experts. And topics are driven by hospice nurse recommendations from some of the research that we did at St. Jude. And the curriculum calendar is on our website, which we will share throughout the presentation. And that has a summary of the dates and the topics as well. And there will be a lot of different palliative care experts throughout the year. Next will be our case-based discussions. So we really encourage participants to submit cases, and we'll go over the online form later on in this session, but we want to engage in real-time problem solving with y'all and allow y'all to ask questions and bring these cases to our experts that we have coming on throughout the year. So if y'all encounter a case, a pediatric case that whether it's symptom management or communication or bereavement, something that's causing some distress, or you don't really know what the next steps should be, please feel free to submit it and we can talk about it in a future session. And then after the session and the discussion with the experts, we'll provide some feedback and recommendations. So again, we want this to be helpful in y'all's practice. And then lastly, we'll have our mindfulness activity at the end of each session. We've heard from hospice nurses that it would be helpful to learn how to build some resilience, because it's really hard to take care of these pediatric patients, and we totally agree. And we also know that mindfulness is one way to build resilience. Also, we recognize that mindfulness may not be for everyone at this exact moment in time. And so we've been purposeful in putting this at the end of this session. So please do not feel obligated to stay if you prefer not to. And again, the mindfulness activity as part of the session will be recorded and available on the website for later access as well. So here's the website I mentioned. It includes a lot of information about our sessions, the curriculum, registration form if you want to send to other colleagues to join, the case discussion form, and then the recordings, as well as additional resources. And we feel free to contact us through our email. Maggie and myself will be monitoring this regularly and are happy to answer questions or take suggestions or feedback. Okay, before we dive into the didactics, just want to take a quick pause. Does anyone have any questions now or any thoughts or concerns about the structure of the sessions and how they'll be run in the future? Okay. And Maggie, anything in the chat?
No, but I'm going to link the website, our LMH PCO website, if anybody wants to access that.
Awesome, thank you. But now let's start this brief didactic portion of our session today. We're going to highlight some of the differences between pediatric and adult hospice. And this is meant to be a very general overview of key differences and preview many of the topics that we're going to explore in depth in future sessions. Big difference for pediatric versus adult hospice is the age range. We have a wide age range in pediatrics. We could be seeing a 24-hour-old baby, or we could be seeing a 28-year-old young adult. And so this also leads to a huge array of developmental needs. Patients' understanding of their illness and how they process decision-making is going to change over time as they get older and based on their age. And as pediatric hospice providers, we really need to become experts in communicating with patients and families across these age and developmental ranges, which differs a lot from most adult patients. So we'll focus on this in our communication lecture in the future, and that's actually going to be our next session in February. Another big difference is the large variety of hospice qualifying diagnoses. And so many of these are extremely rare. And so sometimes even ourselves at Children's Hospital in New Orleans, sometimes we may only see one of these in our entire career. So I just want to reassure you that you do not have to be an expert in things like Bacterial or Charge syndromes. It can kind of be like an alphabet soup in pediatrics. But you do not need to be experts in these things, and you just need to know who to call and how to get help and what resources you have at hand. Okay, so this is one of the biggest difference in pediatric versus adult is concurrent care. And I want to just go ahead and pause and see out of all the participants who has heard of concurrent care or provided this type of care to patients in the past. And feel free to either unmute or share in the chat.
In the chat, Dr. Autry, Courtney Kelly said that we take care of a lot of concurrent care peds. So yeah.
And Courtney, you said you were at Heart of Hospice, is that correct?
Yes, ma'am.
Okay, yeah. And I wonder, have y'all experienced any challenges with providing concurrent care?
Yes, mainly because even though those of us that are still, developing our program, we understand concurrent care a lot. the agents don't typically have a great understanding of concurrent care. So as they are accepting referrals from places, maybe not like Children's, that really help us direct and all that and really help set it up prior to getting home. So if we take patients from like Texas Children's, they're not always so proactive in getting that set up for us before they come home. So, and then the agencies don't realize what it means. So we end up taking on a lot more challenging work than we could have if we would have known ahead of time. So supplies are always difficult to find through our normal channels. Once we realize they should be concurrent care, we usually know which channels to run down at that point. But sometimes we just don't know. That's been the biggest difficulty.
Yeah, and thanks for sharing that, Courtney. And we're going to talk a little bit more about that as well, because that's definitely, you're not the only one experiencing that. So the Concurrent Care Act, it was actually a part of the Affordable Care Act, the Patient Protection and Affordable Care Act that was signed into law by President Obama back in 2010. And this requires all state Medicaid programs to pay for both curative disease-directed therapies as well as hospice services for children under the age of 21 who qualify for hospice, which means that they have a prognosis of less than 6 months. The hope is that this allows children to live as long and as well as possible. So this provision affects children who are eligible for Medicaid or the CHIP program. And all Medicaid programs are required to provide medical curative services as well as hospice services. Obviously, this is, like we said, specific to Medicaid, but thankfully a lot of private insurance companies do default to the Medicaid policies. And so most of the time, thankfully, we haven't had any major issues trying to get private insurances to cover concurrent care, but that is something to be aware of. And then states would continue, so Medicaid, states through Medicaid would continue to pay providers, oncologists or neurologists, providing curative services using the payment methodology approved for those services. So they would go through regular insurance. And states will continue to also reimburse for hospice services within the hospice benefit. So most importantly, hospices are not responsible for providing or paying for curative treatment. And I think it's been really difficult to implement this concurrent care because there was very little guidance provided after the legislation was passed. So there were no clear guidelines from Medicaid services on how to implement this. And I'm sure, like Courtney has said, many of y'all have experienced this within your state. And I know within Louisiana, it took years to really revise our language and try to make sure that the language was clear in the Medicaid manual so that hospices weren't taking on this extra cost and that our patients were able to benefit as they should legally from concurrent care. And so a big part of that, I think Courtney mentioned as well, is with supplies. DME companies, I know our team has also faced calls from medical daycares that call and say, oh, now they're in hospice, so they are not eligible to stay in medical daycare. And that's not the case. So it's still a lot of confusion, and we still have to advocate a lot and make sure our patients are well educated so that they can get that extra support. As a result of all this confusion across all of the states, not just ours, the NHPCO has created this wonderful toolkit, the Concurrent Care Act Implementation Toolkit, to help guide hospice agencies. It includes flow diagrams such as this one. And while this is a good start, again, it's not comprehensive. So it doesn't include guidance about things like DME, tube feeds, or transfusions, but it is at least a start. And we'll continue to touch upon concurrent care throughout all of our sessions because, like I mentioned before, it really does impact pediatric hospice care tremendously. And we'll put, Maggie's going to put the link to the toolkit in the chat, and then we'll also try to get it on our website as well. Then there's still a lot of question marks. So the NHPCO encourages the formation of statewide pediatric palliative and hospice care coalitions to continue advocating for this improved care. So Gulf States Pediatric Palliative Care Consortium is our Louisiana, Mississippi, Gulf States statewide coalition formed in January 2019. And we are within the Louisiana, Mississippi Hospice Palliative Care Organization, the LMHPCO, which Jamie is representing today. And we all work to improve care for children with serious illness. And we're actively involved in advocacy with state Medicaid, again, to ensure that effective implementation. And if anyone is not already a member, to learn more or to join our Pediatric Palliative Care Consortium, feel free to email pediatrics@lmhpco.org. Okay, and then because of concurrent care, pediatric hospice patients often have a lot more medications, a lot more technology than adult patients. And so we're going to have a session later on that details how to support pediatric patients with these varying technologies, whether it's G-tube, NG-tube, trach, vent, central lines, all of those things. And then they also, along with those multiple medications and devices, they have many providers. And so it really is truly multidisciplinary care. And so it's important to know who to contact when there's questions, whether about devices or the medications. And so one pro tip is to make a list of the provider specialty contact info. And we at Children's do try to provide that information when we make a hospice referral. So if that's not information that you're getting on a referral, reaching out to the hospital to try to get all of that information ahead of time. Or asking the family. Sometimes the families do have their own lists as well. Also, because of concurrent care, many pediatric hospice patients receive the support of hospice in addition to their disease-directed therapies. And this results in much longer hospice stays compared to the adult population. So our hospice stays can be months, even years, as opposed to days. It also means that many pediatric patients do not have DNR orders or limits on their resuscitation. And this is really a common scenario that comes up with many of our hospice patients. When we introduce hospice here at Chinola, we're often introducing it as an additional extra layer of support in the home. And eventually we work towards building that trust and that therapeutic relationship over time so that we can have more discussions about advanced care planning, La Post form, which is our Louisiana physician orders of scope of treatment, which is a DNR order outside the hospital or can allow for that, as well as autopsy and funeral planning. Those are conversations that we don't always have in the beginning of concurrent care because they plan to continue with their treatments as opposed to simply focusing on comfort at the end of life. And so it can be a bit startling for families when hospices discuss DNR orders upon hospice enrollment. So it's not uncommon that these conversations are not done prior to hospice enrollment. However, they do often occur over time with their primary team. And this is an important reason for ongoing communication between the referring provider, the referring team, and with the hospice care team in the home, because these things are evolving over time. And we'll have this also will be touched upon in the communication session. Again, that's our next session. And then while adults often also have families, obviously many involved in their care, pediatric patients are a little different in that they are always living with their families. And so that's involving parents, siblings, grandparents. Sometimes you have aunts, uncles, cousins, and again, all different ages, all different developmental needs. And so it's really important that we stress family-centered care and address the needs of the whole family that's in that home caring for that patient. And so we'll have a session focused on family-centered care in the fall. Okay, so that wraps up kind of our bird's eye view of pediatric hospice. Before we go into our case discussion, are there any thoughts, questions, or concerns? Anything in the chat?
Nothing in chat, but I did link the websites to those, the toolkit, and then the, I think the Gulf States Consortium website as well.
Awesome. And so before we start to talk about our first case, I just wanted to go through that case submission form in case anyone has something that they'd like to submit for our next session. Oh, that's one sec. Oh, I already had it open. So this is our REACH website that Maggie had linked. So it has that registration link, and then this is the place you click for the submission of a case. Also, here's the curriculum, meeting our team, frequently asked questions, and then our flyer. And eventually, when we put our first video, our recordings of our sessions, you'll be able to click them right through here. So I'm going to click submit a case, and this will bring you to a SurveyMonkey form. And so you'll have name, hospice organization or hospital organization if you're not affiliated with a hospice, and email. And you'll click a case topic, or you can click other. You'll put the patient age, gender, hospice diagnosis, and any other important diagnoses. Describe the case and what y'all are struggling with, and then what the question is for the team. So super straightforward. Again, no patient identifying information. And then you just click done, and that'll come to us, and then it'll be discussed in our next session. And like we said, we'll plan to follow up with recommendations after the discussion. Okay. So for today, obviously it's our first session. We're just going to go with a common case that we've encountered. And we will, so we'll just go with one common case that we've encountered. In the future, we'll try to do at least 2 per session, depending on how many are submitted, spending about 15-20 minutes on each case. And ideally, we would love for the person who submits the case to present just that basic information that y'all filled out on the form. And then we can guide and a follow-up discussion and then the recommendations. Okay, here's our case for today. And we have our amazing nurse practitioner, palliative care nurse practitioner, Stevia, and she's going to serve as our expert for the case today. And then Dr. Morvant will hopefully be able to join in for a bit too. So this is a 7-year-old boy with a hospice diagnosis of metastatic bone cancer. He's experiencing worsening pain on his right lower extremity, and it's really impacting his ability to play and spend time with his family and friends, which is really important goal for him. The hospice team initially started a regimen of oxycodone 5 milligrams every 4 hours, and also an additional dose of 5 milligrams every 2 hours as needed for breakthrough pain. He had some improvement with this for the first couple of days, but then was using 4 to 5 doses per day of his PRN and still not able to do the things he wanted to do. So the team rotated to morphine. And so he was on 7.5 milligrams every 4 hours, and then had an additional 7.5 every 2 hours as needed. And this worked better than oxycodone for a couple of weeks, only requiring 1 to 2 doses. And then it enabled him to be active and play. But now the pain has escalated, and he's requiring 4 to 5 doses again of the PRN breakthrough morphine. And hospice nurses are calling us asking how to optimize his pain management. The way we'll frame our discussion after the case is presented, we'll open it up to the group. So I just wanted to start and see if any of the group any participants had any clarifying questions or any other information that they wanted before we start to review the case. Feel free to use the chat too. Okay. I'm going to turn it over to Stevia, our expert, and see if she had any other questions she wanted to ask.
Yes, so I do have a couple additional questions. First, is the morphine helping with his pain? Are the PRNs helping alleviate any pain, or does he say that his pain still stays at, the level it was before?
Yes. So the PRN is helping, but it's only lasting about 45 minutes to an hour.
Okay. And then what is the total daily dose of his morphine that he's receiving?
His total daily requirement of morphine is 80 to 90 milligrams.
Okay. So when I'm thinking this through, just from the information that we received, I would start to think about adding a long-acting opioid, such as methadone, to his care plan, and continuing to have morphine PRN as his short-acting, and also increasing that dose for his PRN, because it is helping, but it's wearing off sooner than the effectiveness of that medication.
So it sounds like because he was requiring so much short acting, wanting to switch to a long acting to see if that gives better control.
Yeah, and especially taking the burden off the family. He was getting morphine, I think, every 4 hours scheduled, and then additionally PRNs on top of that. So you can imagine the family's probably giving it nearly every 2 hours, which is really burdensome for both the patient and the family, and can really impact the quality of life, which is what our main aim is for him.
Mm-hmm. And then you mentioned going up on the PRN as well. And I may have missed it. Did you already explain why you wanted to do that?
Yes, but I can, so I would want to increase his PRN dose because he is reporting that it is helping him alleviate some of the pain, but it's not lasting for as long as we know the effectiveness of morphine can last. So increasing that dose to help cover that for a greater length of time. Again, easing the burden of administration every 2 hours, and hoping to improve his quality of life through better pain management.
Right. And morphine, for everyone, the morphine, typically we would dose that, we would hope for that to last at least 2 to 3 hours. And so, yeah, hopefully with an increased dose, we'd have more coverage, more relief. And I wondered if anyone has any experience with methadone, or if they've encountered parents who have concerns about methadone. I know this is something even in our hospital that some of the physicians feel uncomfortable with. So it's definitely something that we often have to provide a lot of education about. Stevia, do you mind sharing how you might approach that with either another colleague or a parent?
Yeah, so with families that are hesitant to maybe start a long-acting opioid, always asking them what their concerns are about starting that, what they're worried about, understanding that there's quite a stigma around opioid use now, and concerns about dependence or addiction, and a lot of families not wanting their child to be on a medication for a long amount of time. And so understanding the family's perspective of that, and even in the case of a colleague who, is maybe more hesitant to start a long-acting opioid, understanding the barriers to why they wouldn't want to start that, and then educating on the effectiveness of a long-acting opioid and taking away some of that burden on the caregiver and the patient with having a greater length of time without needing medication. And then also explaining that, the right dose of the opioid is the right dose for the child, and we balance that with their quality of life. And so we want to give the dose that's just right for their child, and we're going to follow, the feedback we're getting from the pain, going low and slow on increasing the medications as needed and following the child's lead.
Yeah, I think that's a great point. I always explain it to parents, like when they're giving that short acting, it's kind of like a wave effect. Like, you give it and it works, and then it drops, and then the level drops down in their bodies. And so then they start to experience a severe pain again. And so their pain's kind of going like this. And we're always like playing catch up, as opposed to when we do a long acting and it's a slow release, we try to find that steady state. And we always have a little bit of the medicine keeping the pain at bay. And then occasionally, whether it's a certain movement or something triggers that breakthrough pain, that's when we give the PRN, and we hope to even get more coverage. So really trying to educate them on the benefits of a long acting, even though that may seem like a lot compared to just the as needed or the scheduled as needed morphine doses that they're used to. And then there are other long acting options as well, both in terms of PO, like morphine extended release or Cadian, as well as fentanyl patches. Fentanyl patches, though, usually this was a 7-year-old, probably need to be a little older. And that's one of the benefits of methadone, is that we have liquid. And so we can really kind of titrate easier, as opposed to like Cadian extended release. You can't really like cut up a tablet, or, you're more limited with those extended releases. Any other input on that, Stevia? Or why you would choose methadone amongst those three?
Well, like you said, formulation of methadone for ease of administration is amazing. And then again, thinking of like a pill burden, especially for a child, and not being able to crush it or cut it because it is extended release is a limitation. And then especially in younger individuals or our patients who may not have enough subcutaneous fat, you really need that for a patch to be effective. So you do have to take that into consideration when thinking about using a patch. And another thing that I always like to remind families also is that, even though we're starting this long acting now, we will be following up closely and looking for kind of that real-time feedback for how this medication is working for their child. And so that we can make changes, as we're seeing things in real time. And that just because we start something, we do need to give methadone time to work. It takes about 4 days to see it at its best state. But giving it that time to work, and then also knowing that just because we've chosen this care plan right now doesn't mean we can't adjust in the future.
Yeah, and that brings up another good point. When you start methadone, do you just stop the morphine scheduled? I think you said it takes a few days. So what would be the recommendation for how to switch from the morphine to the methadone, the scheduled morphine?
So I would give it at least 2 days of scheduled methadone, and then see how your PRN usage of the morphine is going. So if we are starting to decrease our usage of PRNs, then I would start to wean off of the morphine scheduled, but always watching if we're having more PRN usage or not, and just really adjusting based on the specific child's need.
Yeah, and I think that's something that's always methadone is one thing that makes it, I feel like, even more often that providers have concerns with methadone is because there are a lot of different conversions and a lot of different ways to transition from one opioid to methadone. And so I think that's a good approach, and it's important to always lean on your hospice physicians and medical directors, and also again, know who to call if there's any confusion. And like Stevia said, starting low and slow is always a safe approach. But also when you're starting low and slow, not being afraid to give that PRN, especially because it takes a few days to really kick in. So I think that's important to remember, because sometimes I think even in the hospital, some of our nurses, they get nervous because we're starting methadone and we're on a drip still. So like, we don't want to be giving more PRNs, but really the methadone probably hasn't kicked in yet. So it's important to always go by what the patient's showing us and what they need. Does anyone else have any thoughts or concerns about methadone, or things that they've heard of about methadone that we could talk through? Has anyone ever used methadone in the hospice, in a home setting through hospice?
We've never, well, I say never, we haven't used methadone very much for pediatrics. We are very familiar with it for adults, but I'm very excited to hear that you can use it for pediatrics, because it's a wonderful drug, in my opinion, and very underutilized.
Yes, definitely. So yes, definitely is safe for pediatrics. And as you've probably encountered in the adult population, methadone, unlike other opioids such as morphine extended release or fentanyl, methadone can also help with nerve pain. So sometimes methadone can give you more bang for your buck. For example, for this patient, if we were doing Kadian or fentanyl, we might also want gabapentin, which is a medicine that can help with nerve pain, but the methadone can kind of cover both of those things. So another reason to advocate and educate about how methadone can be helpful in certain situations. And then another one you brought up, a good point, methadone in adults versus methadone in kids. So it is safe in kids. And actually, Courtney, you may be familiar with this as well. There's a lot of concerns sometimes about cardiac risk for methadone, particularly with a QTC interval. And thankfully, this is something in the literature has shown us it really does not ever cause a clinical impact in children. So the risk is extremely low, if at all, for children to experience any clinical side effects or consequences from a prolonged QTC. And also, this is a really small theoretical risk. And so oftentimes we're willing to accept this very small risk if the return is such an improvement in quality of life and comfort. So definitely, big takeaway for today is thinking about long actings in general when you're using a lot of short acting, especially when it's scheduled, and thinking about methadone as well. And like Stevia said, methadone, it takes about 4 days to really start to have a steady state, and that's when we would really see its impact. And so you want to wait until that 4-day mark at least before you consider increasing it. But if they are still requiring at least 3-4 PRNs a day, then certainly feeling comfortable increasing, especially knowing that we started low and slow. So that was always the plan. Anything else to add, Stevia? I think we've covered a lot.
No, I think that was everything.
And then anyone else have any other stories or any concerns or lessons or experience with methadone? Even the morphine extended release or fentanyl patches? But just to kind of summarize, it sounds like we would recommend doing methadone, which can be scheduled BID or TI twice daily or 3 times daily. But certainly a good approach, like Stevia said, to decrease the pill burden would be to just do it twice a day. And then also increasing that PRN medication, since it's not working as long as it should, by at least 50, even 50 to 100%, depending on how much relief it's providing. Okay. And then we'll wrap up each session with a couple of helpful resources. So this is the link that we provided earlier. And so again, this will be in the recording and it's in the chat. And we just want to thank you guys again for joining. Our next session will be facilitated actually by our nurse practitioner, Stevia. Like I mentioned before, me, Dr. Morvant, and Stevia will be alternating who's facilitating each session throughout the year. And then we'll also have Dr. Morvant as our didactic presenter next week, discussing how to navigate difficult communication with patients and their families. In the meantime, you can email us at reach@lmhpco.org with any questions, comments, or suggestions. And then, like we said before, you can also find that case discussion forum at the website. And we really welcome any cases that y'all are either dealing with now or have dealt with in the past that you'd like to all discuss together. And then that next session date is February 16th, 2023. And like I mentioned, I will be probably in the hospital having my baby. So I look forward to seeing y'all again when I'm back in May. But we're so excited to have all of y'all participating, and we can't wait to get to know everyone over the next year. And I'm going to end with Stacy presenting our mindfulness activity. She is our integrative therapist here at Chinola, and we really appreciate her taking the time to help give us all some resilience in the middle of our day. So actually, before I turn it over to Stacy, one last chance. Any questions or concerns or anything to address? Okay. Thank y'all so much. And also, I just want to acknowledge all of the different areas of Louisiana that are represented on this call. So we really are already creating such a strong community throughout the whole area. Okay, Stacy, go ahead.
Hey, y'all. I'm Stacy. The first thing I think is we've been sitting for a long time. I don't know about y'all, but maybe just stand up and take a little stretch, because if we're going to be mindful, if everybody can, I don't know, I always tell the kids, just get your wiggles out. I don't know about y'all, my bottom is a little bit from sitting, stretch a little bit, wiggle. And then when you're ready, just kind of sit back down in your chair. And if your chair allows for you, mine's a little high, but if you can just put your feet flat on the floor. We have on the screen a progressive muscle relaxation. Just didn't want to do anything too deep and fall asleep since we've been sitting for a long time. But this is something that can be really nice as you're trying to go to sleep at night. But even if you just have a few minutes, sometimes during the day, you might feel your shoulders kind of climbing up as you feel a little bit stressed. So just take a nice deep breath in, and you can do this with your eyes open or closed, whatever you feel comfortable with. Take a nice deep breath in. This says close your eyes, but wherever you're comfortable. And when you breathe in, picture that fresh air kind of coming in through your nose, going up through your brain where we keep all that stuff that we think about all day. And picture some of that stuff just going out with your out breath. So breathing nice fresh air in through your nose, up into your brain, and breathing out any heaviness or stress with each out breath. And breathe that air one more time, just to kind of ground, and picture your feet as you're breathing out that last out breath. Picture them grounding yourself into the earth. Shift your attention now to the bottoms of your feet. We're just going to go through each area of the body. And if you can just take your feet and squinch your toes, squeeze your feet tight as you can, and count to 3. 1, 2, 3, and then let go for the count of 3. Go to your calves and squeeze your calves, kind of your knees and calves, as tight as you can. 1, 2, 3. And then release and let go. And count to 3. You can go up to your thighs and really squeeze those thighs and like your hips and maybe your butt muscles. Squeeze all that real tight. Count to 3 and let go with that out breath. Just letting that stress go down into the chair and into the earth. You can get to your belly. Focus on your belly and tighten it as much as you can. Kind of like roll yourself in if you want to. 1, 2, 3. And then release and let go. 1, 2, 3. You go to your shoulders and your neck. So this is one that you're going to want to remember when you feel. You can just do this one part. You don't have to go all the way through all your feet, neck, head. Pull your shoulders all the way up to your ears. Just pull them all the way up. And squeeze, 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 squeeze. 1, 2, 3. And then roll them back as you release. 1, 2, 3. And really picture any stress going down from your shoulders out through your hands into the earth. Next, you're going to go to your arms and your hands and squeeze your hands and your arms really tight. 1, 2, 3. And allow them to relax. And again, releasing that stress into the earth. And then the last thing is to scrunch your face up. And if you can scrunch every single muscle in your face, picturing that you would take all that stress to the tip of your nose. Letting it go. 1, 2, 3. Let that go. And then just let your face calm and relax. Take another nice deep breath in. Breathe it into your brain. And go. Come back. And if you want to keep your eyes closed for a moment, you can. The intention with any of this is to put you in the mindset that you can take any piece or part of this. It may even be scrunching your hands, squeezing your face and letting go. Doing the shoulder shrug, just something small when you're at the bedside or before you go and with the patient or right after you leave. Sometimes we pick up a lot of stress from our patients when we're dealing with this stuff. How do you let go and release some of that? So these are just some little tips. You also feel free to, y'all can print these if you want to, and sometimes share with patients, especially pediatric patients. I don't know, am I supposed to say they're not, that you can share that? I think that they can print those things. I don't know. But it's something that you can share with patients as well, especially pediatric patients, and just keep it kind of pediatric friendly. And they like doing a little squeezing and letting go of. Studies show also that the things that we do for ourselves, if you can learn how to do this for yourself, that we're more likely to share that with our patients. And sometimes that can help to create that bond too, and sharing it with the parents as well. I know that was kind of fast, but at the end of this presentation, we don't want to take too much time, and it just kind of to show y'all that really just 5 minutes can change your mindset and shift your energy just a tiny bit. Do we have any questions or comments about the muscle relaxation? If not, unless Ashley has something, we gift everyone maybe 10 minutes back.
Yeah. Thank you, Stacy. And we'll either put a link to this PDF or share the slides on our website. So you guys can have access to this graphic and use it again for yourselves or with your patients. Again, thank you all so much, and we will see you next month.
Good job. Thank you all. Take care.
Bye. Thanks, everyone.